Good afternoon and welcome to the Department of Geriatric Medicine Grand Rounds. This CME activity is jointly provided by the Queen's Medical Center and UH-JABSOM Department of Geriatric Medicine. Before I introduce our speaker, please enter the name and credentials of people viewing Grand Rounds for CME attendance purposes. As a reminder, evaluations are required to get CME. You can find the evaluation form by following the link in the chat box at the end of this presentation or on our invitation or on our website. CMEs will be sent out by our sponsor in mid-January every year. Your comments are very important to the planning committee and will be used to plan future programs. It's my great pleasure to welcome our speaker today. Dr. Marianne Antonelli received her bachelor's in science degree in biology at Fordham University, New York, and graduated from SUNY Upstate Medical University with the MD degree. Following internship and residency in New York City, she completed a fellowship in rheumatology and immunology at NYU Medical Center. She taught as a clinical instructor in medicine at NYU for many years, then made a dramatic move to be chief of internal medicine at LBJ Tropical Medical Center for a year. As a former Army National Guard reservist, she transitioned to be chief of rheumatology at Tripler in 1979. She has worked for many years as a clinical rheumatologist through the University of Hawaii, Queen Emma clinics, and in the community. She joined the VA Pacific Islands healthcare system as Chief of Rheumatology and Associate Chief of Staff for Professional Education when she retired from UH. She continues to teach clinical skills to medical students and rheumatology to residents from JABSOM and Tripler. She has published articles on rheumatology and medical education. She's an ardent advocate for promoting professionalism in the teacher-learner relationships. Many of her articles have also dealt with teaching clinical skills and enhancing interviewing techniques. Please join me in welcoming Dr. Marianne Antonelli.
Thank you, Dr. Masaki, for the very kind introduction. I will briefly turn on my video, but I don't want to interfere with the bandwidth that we sometimes get trouble with. I am working from home today, so this is the issue. So I'm going to go shut off my picture. You don't need to see me. The topic that Dr. Masaki challenged me with is to talk about rheumatoid arthritis in the elderly. And I would love to get your feedback, since you take care of a lot of elderly, not that I don't, but you may have a different perspective about what I'm going to discuss. So please feel free to break in anytime or just leave messages in the chat, or I will, poll you later on. So there we go. So I wrote these objectives for the meeting, which were to summarize at least one important difference in immune function in elderly, identify characteristics and challenges in diagnosis of elderly patients, and then explain the challenges of treatment. That was pretty simplistic, so I actually expanded them to this. Is that the diagnosis of elderly rheumatoid arthritis is one of two. And the definition of elderly in the rheumatologic literature goes from over 50 and over 60. So it depends on who you're looking at, but I think the concepts are the same. The second issue is, how can we distinguish between patients who age? Do they have RA in late onset? Isn't it different from those who have it earlier on? The literature in rheumatology now calls it elderly onset RA or EORA, and I'll use that. I'll still say elderly onset, but my slides may say EORA. That's the elderly kind that starts after the age of 60 in most literature. And are they different? So I'm going to go over a little bit of background pathophysiology. We're still learning a lot, and I think we have a long way to go. And some of the complications attributed to rheumatoid arthritis, and some of the issues for evidence-based treatments is scarce, but there are some suggestions in the literature, and I'm going to review some of those. And of course, treatment will help all elderly patients with rheumatoid arthritis gain physical and mental capacity with the goal of minimizing risks. And just because people are elderly doesn't mean they shouldn't be treated, and that they shouldn't be treated appropriately. Okay, there we go. Just to remind you what rheumatoid arthritis looks like. What are the clues in these pictures that tell you that it might be inflammatory arthritis? And as I'll show you in just a second, the important part, can you see my mouse, guys? I hope.
Yes, we can. Yes, we can.
Okay, good. Metacarpal phalangeal joints are swollen. And that's a big clue that if this patient's coming in with arthritic complaints, that this swelling is very characteristic of rheumatoid arthritis and a few other inflammatory arthropathies, like in lupus. But the chronicity of this is characteristic with this degree of swelling in rheumatoid arthritis. But this is a late finding. This patient also has some swan necking deformities, which is hyperextension at the PIPs and flexion at the DIP. Again, these are late manifestations, and we'd rather not have our patients get to this. So the symptom complex is joint pain and stiffness focused on the MCP joints and the PIP joints, particularly early in the day, that persists for usually 40 minutes or much greater, up to 4 hours in a lot of patients. And then just kind of abates as time goes on. So the question that's really important, and it's really hard to come by with some patients to get the answer, is, and I will share with you what I say. I say to patients, how long does it take you to get feeling as well as you're going to be for the rest of the day after you get up in the morning? And I don't clue them into any word like stiffness, because they may not use that. They may not use pain. Whatever it is, I let them answer that question if they possibly can. Many times they say, oh, well, I just move around no matter what. That doesn't give me the answer. So it's sometimes very difficult to clarify. But that morning stiffness is a characteristic of an inflammatory arthropathy. And the focus we're looking for in rheumatoid arthritis is the peripheral joints. And this becomes important as we talk about polymyalgia rheumatica later. So you may not see this in a patient whose onset is rapid and soon, unless they've had it for a while. This degree of swelling is unusual, but in the elderly onset, they may have more swelling early on than the younger patients who have onset of rheumatoid arthritis. So this is another view of the same, a different patient, but of the same phenomena of a lot of swelling. This is all soft tissue swelling of the synovial membranes within the metacarpal phalangeal joints. And you can see the swan neck deformity in this particular finger of this patient. Now, if you can see that it's extended, now some of these patients can make a fist, and it may not impair their ability to use their hands, but if it gets stuck in extension, you can see this is not a very functional hand. And that's really important to any of us, particularly the elderly, in their independence. Radiographically, this is to demonstrate a normal hand and a fairly advanced but not terribly eroded arthritis patient. There's periarticular osteoporosis. And I learned this from a radiologist early in my training, is that if you kind of sit back and just squint, it looks like the bones disappear at the joints. If you squint at this one, maybe it's a little thinner there, but not anywhere near as much as this. This is periarticular osteoporosis, which is also characteristic of an inflammatory arthropathy and develops pretty quickly and sometimes sooner than the swelling, the synovial swelling. This one is a more advanced case because you can see that there's apparent narrowing of some of the metacarpal phalangeal joints. So this is really more advanced disease. I think the radiologist here, I didn't put these little arrows in, is trying to say that this is an erosion, but I'm not sure it is an erosion, but that's where you would look for it, is at the metacarpal, the heads of the metacarpal bones. Not usually the distal bone, the next joint going, the next side of the joint. It's usually the more proximal part of the joint, no matter which joint it is. All right, so as people involved with elderly patients, you see a lot of osteoarthritis. And I want to remind you that the differences between these two It may be, it's really a location. This is a standard picture. In rheumatoid arthritis, the joints affected are the metacarpal phalangeal joints, the PIP joints, and practically never the DIP joints in the inflammatory process, though they may be fixed. The joints that are hyperextended in a patient who has swan necking of their fingers, the PIPs may not be involved. This is all because of mechanical changes at the MCP joints. So the tenderness and swelling may be at the metacarpal phalangeal joints, not at the PIP joints. And very, 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 so rarely at the DIP joints that I would probably say there's another process going on. And there's no rule that says you can't have two different kinds of arthritis. Now, this is opposed to the osteoarthritis patient who has usually bony type swelling, as you know, hypertrophy, the Bouchard's nodes at the PIP joints and what we call Heberden's nodes at the DIP joints. And that is just bony hypertrophy that's there. And then you can also see, and this doesn't really show it, is that an osteoarthritis is really at the base of the thumb where the first carpal metacarpal joint is. It's a very annoying symptom to patients who have osteoarthritis of the hands. Now, this is as if there's a really clear distinction. Unfortunately, or well, I guess it's maybe fortunately, there are cases that are inflammatory osteoarthritis that are not rheumatoid arthritis. They tend not to have as much morning stiffness, but they do have swelling, inflammation, and redness, in particular the DIP joints, and it's extremely painful, much more so than the patient who comes in and says, gee, my fingers look funny. Rather than saying my fingers look funny, they come and say, oh, I really hurt. So there's a big difference. Rheumatoid arthritis patients don't usually come in complaining of deformity. They complain about pain. And osteoarthritis patients may complain about deformity and some inability to do things because these big bony excrescence get in the way of good hand function, and it may also be painful for them to use them. So who gets rheumatoid arthritis? Well, you know, this is a changing and evolving field. There are genetic markers that appear to be enriched in those who have rheumatoid arthritis, and that's in the HLA-DRB series. Though that's not enough. And I'll go down here to this, the third line down is that identical twins only have a 15% concurrence, and they all have the same HLA types. So it's obviously a lot more. And it's really interesting that smoking will make rheumatoid arthritis 20 times more likely in a patient with the right HLA subtype. So the environmental triggers of smoking, or one study showed that living near a freeway did that too. So there are I would now pollutants might be the correct word, but chemicals that change some of the cellular components in the respiratory tract that may be inducing some of the changes in the cells and the components of the cells, particularly citrullinated proteins that rheumatoid arthritis has antibodies to. So that the twins are interesting. It's certainly 4 times what it might be with non-identical twins, but it's not the only thing that will make someone susceptible to rheumatoid arthritis. Now, it's interesting. Some papers say rheumatoid arthritis is in 0.5%, and some papers say up to 2% of the general population. It is the most common autoimmune disease. Certainly 10 times what we might see with things like lupus and some of the others. I think in my practice, at least, psoriatic arthritis is catching up, but the mechanism there is probably different. Okay, so anyway, what we do find across the world is that rheumatoid arthritis is increasing in the elderly population. Now, that may be because of successful aging of our population. Thank you, geriatricians. And that people who might have not made it to the geriatric age group with their rheumatoid arthritis are now elderly with rheumatoid arthritis. and it also appears that we're recognizing elderly onset of rheumatoid arthritis, which may probably be somewhat different, but not a lot different. So how do you diagnose it that's where we are. Now, the other piece that's happening, and I didn't find this in the literature about elderly onset rheumatoid arthritis, was that we're finding that there are preclinical clues to rheumatoid arthritis. And there are a number of studies in Europe who have looked at this, and I don't recall, they're not big enough to identify particularly the over 60 age group. But what they look at is people who have polyarthralgias, or maybe they just do a population study, but they don't do, no one does the population studies with the blood tests because it's too expensive. So they take a group of people who might or might not have a true symptom, and they check them for antibodies to citrullinated proteins. And when they have found these in patients, they gather the patients, and then they do a comparative study of treating some and using placebo for the others to see if they can interfere with the eventual outcome of development of rheumatoid arthritis. And there appears to be some benefit to treating early before there is clinical inflammatory changes in any of the joints. But this is not absolute, and it's a really hard way to get there. So we're looking for other better markers. We can't do a CCP assay on all patients, all people. And it's clear, at least there was one military study where they had some bank blood, and they went back and tested those who eventually had rheumatoid arthritis. They tested some of the banked blood they had. It was 10 years old, and there was a high prevalence of CCP antibodies in that banked blood 10 years before the clinical diagnosis of rheumatoid arthritis was made. Another study said it takes only 5 years. So that's an interesting thing to look at, and I don't know if that has been done specifically for the elderly population. I couldn't find it. So there's also growing evidence that other things other than airborne pollution could be influencing the immune system in such a way as to bring on conditions such as rheumatoid arthritis. And of course, the periodontal and intestinal bacteria are of great interest. And so how does that affect either the onset or the development once there is a trigger to a whole bunch of different diseases, as you know. Even in fibromyalgia, I think the intestinal bacteria have something to do with it. So, yeah, this is kind of too broad, and we don't have these very specific answers yet. But keep your ears and eyes open and your brains open to this, because I think something is going to develop in the next maybe 5 years to give us a better base and grounding on what to do. Well, at least to understand it, and whether it gives us a therapeutic or preventative therapy, we're not sure. So traditionally, as you know, I learned this many, many years ago, that women at the ages in the 20s and 40s, unfortunately at the childbearing ages, have twice the incidence of rheumatoid arthritis than that in men in the same group. Okay. Although there can be a rapid onset at all ages, the younger patients, the onset appears to be a little bit more gradual than in the elderly populations. And I had mentioned the fact that the I call it CCP antibody, and the general interest amongst some of my colleagues is to call it ACPA, which is the same citrullinated antibodies to citrullinated proteins, appear to be present. How long before, we don't know, because nobody has done these studies that much longer term. So there's interesting thoughts that maybe we could prevent rheumatoid arthritis, but it's a small population that we would be able to identify at this point in time. And maybe this information will come to us in the elderly patients at some time. So what's the difference about elderly with rheumatoid arthritis? Well, it appears that the male prevalence is higher. It's not, it almost equal to women. When they've done the studies, there may be 48% of the patients who are men rather than, 1 out of 3 patients. Now it's closer to 50%. And that they elderly tend to have a more acute onset of symptoms. And I can't tell you how this is determined, because the other problem I would have is that as people age, they're more tolerant to aches and pains of being older. And I'm hoping that this is not missed early on, and not until they actually present with more inflammatory signs is it diagnosed. Also, the literature suggests that systemic features may be more common, and I'll get to that in a little bit. They also may have large and proximal joint involvement, like the hips and the shoulders, in addition to the peripheral disease. Now, when you hear that, as geriatricians, you should think of polymyalgia rheumatica, because that is a proximal large joint symptom complex. And so that this polymyalgia rheumatica can have, as you may or may not have seen, have patients who appear to have peripheral arthritis along with their proximal. And this becomes very confusing. Okay, and if you're confused, the rheumatologists are too. So it's interesting that if you see a patient who happens to have fairly rapid onset with large proximal joints and peripheral joints, this could be rheumatoid arthritis. It could be polymyalgia rheumatica. So the alert should be, if indeed it is polymyalgia rheumatica, those are the patients that are more likely to have large vessel arteritis. And so you have to be alert to the symptoms of giant cell arteritis. And so any patient that I see who has rheumatoid arthritis, who got it fairly rapidly in the elderly time frame and has large joint, but maybe more predominant peripheral joints, I'm always asking them the giant cell arteritis or temporal arteritis questions. So the other interesting thing is they tend to have, the elderly with rheumatoid arthritis tend to have less rheumatoid factor positivity, yet they may have worse functional outcomes than the young patients who have seronegative rheumatoid factor seronegative rheumatoid arthritis. If they have erosions, this predicts worse outcome, even if they're seronegative. And the anti-cyclic citrullonated peptide antibodies predicts more destructive radiologic disease than even in the young people, though that's a pretty good indicator that someone might have more significant diseases, particularly if they have high titers in any group, any population. So what's the difference? Well, maybe male predominance, maybe acute onset. They may have more systemic features. They may have a combination of peripheral and proximal. And this polymyalgia rheumatica confusion exists, and that doesn't tend to exist in young because we don't believe it happens under the age of 50. And they may not be rheumatoid factor positive, yet they may develop erosive disease. So people have been looked to see what's different in the elderly. And there was one Taiwanese study, and this is only one study, so there's not a lot of corroboration of this data, that said that the elderly onset patients had significantly higher IL-6 levels and lower TNF alpha levels in the peripheral blood. Those with the highest IL-6 levels happened to be, that was associated with the men more than the women. And those that had high C-reactive protein had more PMR or polymyalgia rheumatica-like symptoms. The high TNF alpha patients seem to have more constitutional symptoms, which may reflect systemic symptoms also. And they happen to have the higher levels of anti-citrullonated proteins antibodies. So more studies will be coming to figure out is there a separation in the different categories, because we haven't seen this in the younger patients quite as much, enough to say, hey, well, there's something different. So just as the very last paragraph is one of the scores we use to see how disease is going, whether it's moderate, mild, or goes into remission. We may use a part of the DAS-28, which is you count symptoms of all the 28 joints. and patients' global responses and how they're doing, and the physicians, and then you tag onto that SED rate. There's another one that has C-reactive protein with it. And since elderly people may have elevation in the ESR anyway, just because they're older, which we don't understand, this can confuse and may change. If you look at the literature, if they use the DAS28 ESR activity measure, that may kind of confuse the results. So people may have remission, yet their DAS28 ESRs may be somewhat higher than we would expect for the younger population. So this has to be worked out. There have been studies that say these disease activity scores are just as reliable in young as well as old, but this suggests that it might not be. Okay, so then we get to the concept of immunosenescence. Now, I don't know how much of that is hard science. It's developing science, but we do know that the elderly, and thinking about COVID, have a greater susceptibility to a bunch of respiratory and viral infections, have increased difficulty with vaccine responses. They have insufficient protection against malignancies, and they have a predisposition for unopposed tissue inflammation in atherosclerotic disease. And for those who are starting to believe that osteoarthritis does have an inflammatory component because of the cartilage damage, we know that happens as you get older, as we all get older. And then also in the neurodegenerative diseases, as well as kind of slowed wound repair mechanisms. These are all interesting, you know, it's just all the systems are getting older. Well, maybe not just that. Let's go, there we go. Okay, so there's literature developing on the T-cell aging and rheumatoid arthritis. And it turns out that there's a accumulation of CD4 T cells that have lost the expression of their ability to talk to the dendritic cells, and that's the CD28 positive T cells. They also, in aging, premature. Remember, the title of this is T-cell aging and rheumatoid arthritis. I'll get back to why that's important in a little bit. So prematurely, telomeres are shortened, and in different cells, including naive T cells, neutrophils, and bone marrow precursor cells. There's increased DNA breakage in the CD4 T cells, and the repair response is activated, but it might not be effective. It depends on which cells it's effective. There's some metabolic reprogramming of CD4 T cells, and these are some of the metabolic changes. And one is a glycolytic flux that's reduced, and this is PFK is a protein kinase signaling issue. They see reduced ATP production. You can see enhanced shunting into the pentose phosphate pathway, and excessive reductive elements like NADPH, and the lack of reactive oxygen species. And part of this is in the mitochondrion, and then they're looking at mitochondrial DNA and the changes of mitochondrial DNA that leaks out into this both the cytoplasm as well as into the serum, into the blood and tissues, and what that altered DNA looks like, and whether that's part of some of the issues that are going on. Now, the reason I said look at this as T-cell aging in rheumatoid arthritis is this is immune senescence in the elderly population, but it also occurs in patients with rheumatoid arthritis who have rheumatoid arthritis when they're younger. So these are the cell biologists talking about T-cell aging in rheumatoid arthritis. They say they see the same thing that happens associated with age alone, even without rheumatoid arthritis, in the younger populations who have rheumatoid arthritis. So this is an increasing informational field with a lot of theories. And the question comes up is rheumatoid arthritis due to an environmental toxin affecting how DNA synthesis is done, or is it, there was always worried about an infectious agent causing it? Is the other factors that are associated with aging, for instance, atherosclerotic disease and vascular disease, are those due to this DNA change and T cell changes, and which induce inflammation, rather than just too much cholesterol? What is the damaging component? And this is, of course, a growing area of interest in preventative cardiology, in inflammatory research, as well as basic cell biology. And maybe you guys have the answer, but I don't know. But it was a lot to gather when I was trying to get this put together, because there's so much information out there. They don't contradict each other, but they get into such cellular mechanisms. If I were a cell biologist, I'd probably understand it better. So why do we care about rheumatoid arthritis? So what if your joints don't work? Well, it's more than that. As you know, there are systemic complications of rheumatoid arthritis, particularly cardiovascular disease and cancer. So it used to be said that someone with poorly responsive rheumatoid arthritis to treatment had about a 10-year less life expectancy than his peers who didn't have rheumatoid arthritis. And that life expectancy difference was in cardiovascular disease and cancer. Oh, that's probably the immune senescence issue, because we do know that, well, I'm sorry, it's posited that this immune senescence has a lot more to do with the cardiovascular susceptibility and cancer susceptibility. Probably also certainly helped with poor diet and probably environmental concerns. But there's a huge attribution to our internal senescence of the immune system. And why would it occur in young people with rheumatoid arthritis? It's certainly not, they're not all in the population of metabolic disorder people. You know, we do know that obesity, of course, has more inflammatory consequences, but not everybody, certainly not patients who are young, have obesity as the inciting immunologic problem. So there's something to do with genetics, but it's not 100%. Only 15% monozygotes would have the same thing. There's something to do with how cells are handling some of these perturbations, and whatever rheumatoid arthritis is and whatever it starts, the cellular level is much more important than we ever thought. So some of the things we use can also damage this, the cardiovascular systems, and maybe also affect cancer surveillance. So if you look at the drug information for some of like TNF inhibitors, they say, oh, you got to be careful because it might enhance melanoma or non-melanotic skin cancers. Now, how much of that is due to the diseases they're treating versus the medications is not clear. This is whatever I see in the drug information, I always think, well, the drug company is also trying to protect their bottom line by warning you whether or not it has anything to do with the drug. But it's not really clear. And this keeps on coming, hits us back and forth about whether something is more, it gives you more cardiovascular risk. But it appears that certain medications, like corticosteroids, might have a greater damage or greater effect on the cardiovascular system. I'm not exactly sure why that is. But the other medications that we use probably don't negatively affect cardiovascular and cancer risks. They actually improve it. So if you take a young person with rheumatoid arthritis who now will live into older years, in the old days, they would die 10 years before their peers. And, you know, if the average age expectancy was 72, then they might die at 62, and they never got to the elderly age group. But now they're becoming older, and maybe the reason is we're effectively treating it. So some of you, I don't know if anybody in the audience was around in the years when we only had gold treatment for rheumatoid arthritis. We weren't treating very well. We weren't doing a very good job. So those patients didn't live as long. They got severe inflammatory conditions and severe complications in other parts of their bodies, systemic effects of the diseases. We don't see that anymore. So I think that also has affected, and the literature is starting to prove this, but it's a long-term retrospective, that cardiovascular disease and cancer is not as common as it was as the mortality cause in the patients with rheumatoid arthritis. And we're saying it's because we're treating them better, and we assume that's correct. And they're getting to be older, so that you have now two populations. People who age with rheumatoid arthritis, and then those who get it when they're older. So we don't have to, I don't want you to lose view of rheumatoid arthritis as a systemic disease. There's a significant proportion of patients that have an interstitial lung disease. And of course, osteoporosis goes along with having rheumatoid arthritis. We used to see vasculitis, small vessel vasculitis, that is, neuropathies, Raynaud's, rheumatoid nodules, scleritis, Sjogren's, and Felty syndrome, particularly when the rheumatoid arthritis wasn't well controlled. We're controlling it so much better now. I almost sound like our old professors. They used to say, when I was an intern, I used to see that. No, that's what I'm saying. I haven't seen rheumatoid vasculitis in years. Okay, and there are some rheumatoid nodules. I haven't seen scleritis. Well, I've seen Sjogren's. I've seen one patient with Felty's, but I wasn't sure if that's really what he had. So yeah, rheumatoid arthritis as a systemic illness is becoming less frequent because of the ability for us to treat it, but I'm not sure we're getting to the bottom, and we may be too superficial for the cause of what is going on with the immune system by just treating, for instance, TNF, and maybe the same for JAK, I'm not sure. So the complications, in addition to the medical complications, are the fact that young people can't work. They may not be able to take care of their families as well as they'd like to, and they have all of the mental and depressive consequences of this. And if they need help, do they get it because they're young and they don't have the right kind of insurance? So depression and mental health issues abound. In addition to the fact that as we see the older population, we find that if they have elderly onset, they also have more dementia, as well as all the functional issues. And now on top of having a little bit less muscle conditioning, et cetera, they can fall more and get hurt more. So all of this, in addition to the other diseases that they may now have too, leads to a lot of problems in treatment. But in those studies where they followed some of the elderly onset patients, when they treated their rheumatoid arthritis, their dementia, their brain function got better. They did the SF-36s, and people certainly their attitudes increased and their ability to function improved. So it's not just the joint function that improves; it's the entire organism. Protoplasm gets a little bit better. So I don't know what the successful treatment will help with that. So this is a schema that I came across in one of the articles where they talked about greater than 60-year-old patients who develop elderly onset rheumatoid arthritis. And if they're at high risk for other things, like multiple medical conditions, there was a whole algorithm that I'll show you. But if they're at low risk for that, they're healthy elderly that just developed rheumatoid arthritis, you can use what we use for the young'uns, and that is this treat to target strategy. The target is no disease activity, remission, and use all the drugs that we would use for that. However, if they have other conditions, then you have to tailor your approach differently. So I'm going to go to this. So this is the tailored approach. So you look at what comorbidities a patient has. If they already have cardiovascular infections, cancer, liver, and renal diseases, you really have to figure out which of the drugs that are not going to make any of those worse and might make some better while you're at it, while you're also looking at the polypharmacy part of it and the cognitive dysfunction, because if they can't manage the polypharmacy because they're cognitive dysfunction, you're not going to get out of the gate very well unless they've got a lot of home support. But you guys know all that. But all these other things are important. So someone who has a cardiovascular risk, You don't want to give any more steroids than you have to. But, you know, patients love steroids. It makes them feel so much better, you know. But so you've got to resist that. You might be able to use it intermittently and maybe aim for the lowest possible doses so that you don't make these other things worse, like infections. Combine the immune senescence with corticosteroids in the elderly, and you're set up to get more infections. Thank goodness most of the drugs we're using don't affect the liver and renal, the kidney or the liver, but liver or kidney disease can affect how these drugs work, and of course the metabolism. So one of the best drugs that we always use for everybody is methotrexate. But with people with underlying liver or kidney disease, you have to be very, very cautious. Excuse me, I'm gonna get a sip of water. And then the question comes up about lung disease. Rheumatologists are kind of thinking that maybe what we used to blame as methotrexate, lung disease, may be underlying interstitial lung disease of the underlying disease rather than due to methotrexate. So that's still being argued. But if they do have lung disease, you have to be really careful with certain drugs. Particularly, I would be careful with something like methotrexate in somebody who already has some interstitial lung disease. So people get better when you do treat them. So if this is medicine, this is why we are doctors, and that's why computers can't take care of our patients, I believe. So the problem is there's no treatment guidelines specific to the elderly patients with onset of rheumatoid arthritis. So because the young people are surviving longer, as they get older, they get into that category of more complex patients perhaps to treat. But if indeed we're preventing some of the cardiovascular and malignant consequences of having rheumatoid arthritis, maybe they won't fall into those categories as easily. The recommendations are to avoid corticosteroids or minimize dosage, even though it's such a great drug, the patients love it. Now, it turns out hydroxychloroquine appears to be both effective and safe in most patients. There's some argument in the literature about what the maximum dose should be, and it's 1 milligram per kilogram. So either less than 5, which is the newest coming out, but people are still using less than 6.5 milligrams per kilogram. This just comes from the ophthalmologists who believe that there's more retinal toxicity the more that you take for the longer times. Now, if an elderly person at 60 starts hydroxychloroquine at either of these doses, they are probably not going to get retinal toxicity, and they should be followed regularly at yearly intervals to check the retina. But it's a fairly safe drug for the elderly, and unless they have significant arrhythmias, that won't add to it. And they appears to be quite effective in the elderly and safe. Now, depending on other risk factors, methotrexate can be used, TNF inhibitors are used, JAK inhibitors appear to be efficacious. There's some question about whether rituximab is hitting the right cell lines. Plus, it's a long effective time both on B cells, and it also affects T cells, which I hadn't realized how much T cell effect it is. And the T cells are already dysfunctional, and that may be just people thinking maybe you shouldn't affect it, or they have actual data. I couldn't find it for rituximab. There's also some thought that certain TNFs may be better, like shorter acting ones. And the shortest acting TNF we have right now is etanercept or Enbrel. We have to use it every week. All right. And then there are some longer ones, as you may see in the literature, but the one that's been around the longest, infliximab, may not be the ideal for our elderly patients. It may be simpler to give it to them because they've gotten it when you infuse it, but if you're going to use something like Enbrel and have to have that kind of support to be able to get it injected weekly, that becomes another issue. The JAK inhibitors are great because they're oral. There's still some concern about increased well, there's always increased risks of herpes zoster in these patients, but even more so that there may be a risk, and we're not sure why, for thrombotic disease. And that underlies probably the cardiovascular risks that were put in for a couple of JAKs earlier on. It hasn't been cleared up. The literature seems to say that really there isn't a risk, but FDA has not taken black box warnings off. Okay. Now, don't forget that osteoporosis is increased. So the elderly population is already in increased risk for osteoporosis. So if you should be checking your patients, and you don't have to wait for a man who has a significant inflammatory disease to wait until they're 70 to get someone to pay for it, to get a DEXA screening. You should do it when they have rheumatoid arthritis earlier. That's a criteria, one of the criteria to get a DEXA. You should advocate for your patients to check it out because they should be treated. You don't want to compromise them when they're in a condition that might cause them to fall more often, to have more likelihood of fractures. So my first objectives, I thought I'd give you the answers just in case you had to do it on your questions. So summarize at least one important difference in immune function. Well, after I looked at this, I said, maybe there isn't a difference. It's immune senescence. It just happens earlier in the early onset rheumatoid arthritis. And it happens, of course, in late because that's what happens when you get older. So maybe there is a little difference. Maybe it has something to do with the pool of T cells. You start out with lots of T cells younger, and if their telomeres are shortened and they can't be repaired over a longer time, maybe there is a difference. But it's not really clear. The people who have had rheumatoid arthritis for a long time and that's effectively treated do not appear to have a burden of disease if it's been treated. So that's the good news. So maybe there isn't a big difference, but we'll have to find this out over time. Now, identify characteristics and challenges in the diagnosis. And I said easy for rheumatologists when it looks like RA. We know what it is, whether it's seropositive or negative. It's really hard when it looks like polymyalgia rheumatica. So yes, please lean on, if you can, your rheumatologist if you have a patient that you're not sure where they are. Now, what's the difference in treatment is that polymyalgia rheumatica still has corticosteroids as the primary drug you're going to use, but it really is something, maybe that this accounts for the patients who seem to need to have polymyalgia treatment for a long time with steroids. We probably should be looking now, getting back and doing the tofacitinib or some other thing to enhance their treatment, maybe methotrexate rather than steroids. And if getting steroids, high doses, anything over 5 milligrams a day. And that's sometimes hard for some of these patients. So just be careful. And as I said, it's not easy for the rheumatologist, and I can't imagine that it's going to be easy for anyone else. Now, what are the challenges of treatment in elderly patients? Well, you know them all. Polypharmacy, hepatic and renal diseases, steroids that make patients feel better but are really bad choice. No clear guidelines. We treat them as if they look the same as the other patients, except we look at all the other risk factors going on in their lives. Most treatments for elderly within their own health parameters may work. So some others better than others. But be careful of certain drugs. Steroids, rituximab, maybe infliximab. But the jury is still out, but I forgot the T. So I hope this has helped you. I wish you, I will try to send the slides back with my references. There's one reference I couldn't get the article to reprint for me, but I want to get them so I can at least give you the references and see if you can get them yourselves too, but I'll get them to you. So I'm open for questions. I'll even look at the chat if there are some. Oh, good, there are some.
Thank you, Dr. Antonelli. That was a wonderful talk. And yes, there is one question in the chat. Pedro, would you like to unmute yourself and ask the question?
Yes, thank you for the talk. Very helpful. I think I just wanted, so patients who, have these like mixed features, of both either inflammatory osteoarthritis or polymyalgia rheumatica and RA, would you still consider treating them as RA with meds like hydroxychloroquine, or I guess what would be your approach?
I don't have a very high bar from hydroxychloroquine if I think there's inflammation going on. I tend to use it more, and I think most rheumatologists would. We got used to it using it for lupus. We know that if we treat a lupus patient who's got very, very mild disease, they tend not to get worse. So there's a lot of comfort that we have with it, and it's pretty easy to use in the adult and the elderly patients. If you still think polymyalgia is there, there's no good literature that says it helps with polymyalgia, but you just have to be aware that it will not prevent somebody having giant cell arteritis. Nothing prevents them from having giant cell arteritis. If they're going to get it, they're going to get it. So I would just be aware that if there's a lot of proximal inflammatory kind of symptoms that's still on the differential, I don't think I would stop using it. I would just make sure I'm surveying, make sure the patients are aware to let you know if they have any central temporal arteritis GCA symptoms. Now for the DIP and the inflammatory osteoarthritis, that's an interesting paradigm. I've not used hydroxychloroquine in those situations, though there's some literature that suggests that you could try it. Colchicine might work, and the reason they're inflammatory has been attributed to a hydroxyapatite crystal induced inflammation. But there's probably nothing against using hydroxychloroquine as long as you're careful, and if it helps, that helps. It's not clear why it helps. It interferes with some of it's not the basic pathophysiology of the disease, but it interferes with some of the inflammatory pathways. I don't think we know exactly what hydroxychloroquine does for all of these diseases. It's too good a drug to use, and we haven't learned enough about it. So yeah, I would not hesitate, but just be really careful about making sure that you're keeping a close eye on whatever the characteristics you're treating. And there may be changes. You might find that, oh yeah, their MCP arthritis gets better, but the DIP arthritis didn't, because maybe they're two different mechanisms. There's no rule. And when I was in training, we learned that you couldn't diagnose rheumatoid arthritis if the patient also had gout. Okay, and that's in the old literature. And the only reason for that is the only treatment we had that was effective, besides not that gout was ever effective, was aspirin. And high dose aspirin reduces uric acid so low that you shouldn't be having gout and rheumatoid arthritis together. I think that's why that came out, because I see plenty of gout and rheumatoid arthritis right now. And treating the gout is not enough to treat the rheumatoid arthritis for sure. So people can have more than one inflammatory condition. And so just remember that, especially as they get older, they can have more than one. And gout isn't in this mixture. We didn't talk about gout today, but it really has a totally different mechanism. I don't think it crosses over, though gout can be chronic too, and people have chronic inflammation due to it. But for the rheumatoid arthritis, polymyalgia, inflammatory osteoarthritis, if you're kind of stuck, it's easier. I'd rather use hydroxychloroquine than steroids for sure. Does that help?
Very helpful. Thank you.
Are there any other questions for Dr. Antonelli?
No, but I'm actually going to just speak up. This is on a personal level. I actually have rheumatoid arthritis, and I've been having it for a long time. And I just want to sort of kind of put in a plug for the preclinical disease, because I believe I had it for 10 years before people diagnosed it, because it is an invisible disease. People have a lot of pain and aching and fatigue and inflammation that nobody takes seriously for many, many years, especially if you're older. It's just written off as you're getting older. And so I really think I just want to just speak to that it's important to take these symptoms seriously and not just write them off. Because treatment, I mean, you could, waffle about, oh, should I treat or should I not treat? Well, I'm not sure if they have it or if I don't. And but the risk to that is that the person doesn't get treated, and then they continue to suffer with the symptoms and impact their functioning and quality of life for a longer time. And so what's the downside? That's the downside. So, I don't know, err on the side of giving it a trial.
Yeah, and actually that's a good place for hydroxychloroquine, because the toxicity is so low. And if it does improve the patient, you've got a kind of a clue. Now, when they did those studies for the patients who had long-term fatigue, polyarthralgias, and no obvious or testable inflammatory stuff, it really was a maybe 15 to 20% developed into rheumatoid arthritis. So that's the problem, is we don't know which of a group that may have very similar symptoms will get it. But I think that's a problem. It's clearly there. The other thing that I hear you say, and did anybody say you must have had fibromyalgia? Because that's the other issue, is people label and then forget to look again. And I will tell you, we've seen that in rheumatology a lot. You know, they come to us and they say, "As fibromyalgia is not getting better." I had a patient like that who was 60 who had had ankylosing spondylitis for 15 years, and nobody made the diagnosis because they called him fibromyalgia. And that's not fibromyalgia. So you've got to keep your eyes open, you know, and don't get caught in a diagnostic bias. So
Yeah, and keep testing, because the lab tests change. I think I was seronegative for a decade, right, before I actually turned positive.
Did you get CCP antibodies
I
in the
did
decade
not.
before?
No,
Maybe
because no, I didn't.
it wasn't available. Yeah.
It wasn't. Actually, it was the decade before, was before the new criteria even.
Yeah.
So it was like, you know, wait till you have really bad symptoms and actually erosion before you can actually get a diagnosis, right? So,
Well, hopefully we'll be away from that pretty soon.
right.
Totally.
I'm glad.
Thank you for your personal story.
Are there any other questions for Dr. Antonelli? Marianne, thank you. That was a wonderful presentation, very comprehensive, and really getting us up to date on rheumatoid arthritis. We really appreciate it, and we hope you'll come back to do a different topic for us another time.
Sure. Let me know what you want to, if I can, you know, I learned by doing this because I hadn't checked some of the newer immunosenescence stuff, and boy, wow, has that blown up. So thank you for the opportunity to learn more.
Thank you, Dr. Antonelli. All of you, don't forget to do your evaluation. You need that in order to get CME, and do it anyway, even if you don't. John has put the link to the evaluation form in the chat. So go ahead and click on that, and it'll take you straight into the evaluation. Thank you all so much. Hope to see you again next month. Thanks again, Dr. Antonelli.
You're welcome. Aloha.
Aloha.
Thank you.